Yay! It's so great to be here. I love Hotlanta. It's so good. So I'm going to talk about new agents. And it's funny, I don't know if Paul, he's probably still out having coffee, but his talk is actually going to help quite a bit when we start talking about broadly neutralizing antibodies. So I'm excited to be here, and I would love to have a million questions. These are my disclosures. These are the learning objectives. One is to just think, well, do we really need new antivirals? And I'll talk about that. And then talk about the potential for long-acting and then truly very long-acting therapy and whether that will happen. So these are our goals. I think everybody in the room can kind of buy into these. We want to maintain or restore health to people living with HIV through suppression of viral replication. We want to really minimize the short and long-term adverse effects of our treatment, and we've done a pretty good job of that, I think. And I think this third point, we want to have therapies that are accessible to all people with HIV. And I think that's our biggest challenge. We're pretty good at about 90% of people, I think, or 85%, but there's a substantial number of people where we don't have therapies that are truly accessible. And then, of course, treatment is prevention, and we want to prevent HIV transmission via any route of exposure. So what do we have now? Well, oral therapy, we have multiple single tablets. Many don't have food restrictions. Some have very few, I probably shouldn't have said almost no, but very few drug interactions. There are few frequent AEs, and Jeff kind of avoided the whole weight gain thing, and we can talk about weight gain if you like at the end or during the case thing, because I have some opinions about that. And there are kind of rare, serious AEs with our current therapy. There's some case reports of diabetes that I think are believable on Cabotegravir, but they're rare. And I think they're clear examples of people having substantial weight gain that we don't quite get. We think for people who are treatment naive, both INSTIs and boosted PI therapy is almost resistance-proof. And then we have pretty simple therapies for our treatment-experienced patients that are, even if they have resistant virus, if they're suppressed, but they're not perfect. And now we have long-acting, right? We have Cabotegravir pivirine. It's clearly non-inferior to our gold standard oral therapy in people with previous virologic failure. Without previous virologic failure, people are suppressed. Twice monthly is good. You don't need an oral lead-in. There was a head-to-head at CROI, the SOLAR study, head-to-head with Cabotegravir, TAF, FTC, and there's people are interested in this. Our people who have HIV infection we care for are really interested in this. And there are a lot of other things besides just convenience. There are social behavioral factors, there's quality of life, there's both external and lots of times internal stigma, and potentially, and this was also discussed at CROI, is maybe this can be used for people that are hardly engaged by our current system. People with mental health, housing instability, substance use. And this is the UCSF experience that Monica Gandhi has talked about. And it's something that could be extended beyond San Francisco. But what are the liabilities? Well, oral therapy is daily. What if it was weekly or monthly? That could be better for some people, right? I mean, that would be good. We actually don't have a convenient, safe, resistant oral therapy that isn't either an integrase inhibitor-based or boosted. And for people with highly resistant virus, our therapies are not simple, whether they're either suppressed or rebounding. Long-acting therapy, well, we'd love a long-acting that doesn't have resistance risk, even if you're taking it on time. And that is the one Achilles of Cabotegravir pivirine, right? That some people who take it on time actually don't succeed. It's only about 1%, 2%, very low number, maybe even less than that. But some people taking it when they're supposed to can have virologic failure. And when I start someone on an oral integrase-based therapy, second-generation integrase, I tell them, if you take every pill, you will not fail. And I can't quite say that to people who go on to long-acting. And there's a lot of restrictions to our current long-acting. And if you think about the US, but if you think about the world, there's a lot of NRTTI resistance floating around. And that really kind of hamstrings Cabotegravir, pivirine. And we need longer acting. Every 2 months is great, but it's still hard to go out, find, and treat people who are unable or not accessed by the medical system. And we need something that's affordable and scalable. So I want to say a couple words about lenacapavir. It is a new drug, but it's an approved drug. It's a injectable drug. It's a capsid inhibitor. Right now, it's approved for heavily treatment-experienced people who are failing therapy. So it's not yet approved for heavily treatment-experienced people who are successfully treated, where you're trying to maybe change or simplify. You can probably manage that, but I don't know. I haven't had to write a prior authorization for lenacapavir yet. But it is specifically in the package insert for people who are failing therapy, who are viremic. But unfortunately, there are no long-acting partners. It's every 6 months, you take oral therapy for 2 days, get a shot, and you're good. But there's no long-acting partner. And in the studies that have been done, published in New England Journal, obviously, if you stop taking your oral therapy and you have a long-acting floating around, that's a risk for resistance. And this is not a completely resistance-proof agent. So how we're going to use lenacapavir is really something of interest. And I'm sure, given that some of you, 30% of you, follow more than 500 patients, I thought that was phenomenal. You're going to have ideas about how you might use lenacapavir. So let's get into the new agents thing. So I'm going to talk about Islatravir. Who has heard about Islatravir? You can raise your hand. We don't need a question. All right. Good, great. So Islatravir is a very cool drug. It's a nucleoside reverse transcriptase translocation inhibitor. So part of its action is a little bit like a standard NRTTI, because it does compete with endogenous nucleotides, but it also prevents the reverse transcriptase from sliding along, so it blocks translocation. So it's incredibly potent. It's a remarkably potent drug. And with 0.5 milligram in the original studies, you could suppress viral load for more than a week with one dose. So it's very potent and it has a long half-life. And we are very excited about this agent. And at CROI, we did see, this was a switch study, large, fully powered, 300 people per arm, classic switch study. People on bictegravir, TAF, FTC were randomized to either islatravir, doravirine, or stay on the bictegravir. FTC was placebo-controlled, randomized, blinded, and you can see it worked very well. And there was very, very, very little resistance. There was only one documented virologic failure on islatravir, doravirine in these suppressed people, and there was no resistance, and they probably weren't taking the drug because they couldn't detect islatravir. So that all sounds great. I want you to note, though, that was giving 0.75 milligrams. And this study was completed over a year ago. You might wonder, well, why didn't they publish it? Why this isn't in the New England Journal? And it's because something happened, on the way to the forum, right, Mike? That's it. You got to keep Mike's attention by movie jokes. I don't know any shows except Tick, Tick, Boom, which I really liked. And I would urge everybody to watch Tick, Tick, Boom. You can get it on Netflix or something. But anyway, clinical development was paused because there was a lymphopenia. So this drug at the dose of 0.75, and I'll show you at a couple other doses, actually caused lymphopenia. And guess what? If you get lymphopenia, what else do you get if you have HIV? You get CD4 openia, whatever that is, CD4 So it's a problem. So if you look at the bottom of the slides, I'm not going to try to point, but on the left, they were going to give once a month oral PrEP, which a lot of people felt like, whoa, this is a big deal. And you can see this was 60 milligrams of this stuff, right? So, and you can see there was substantial declines in lymphocytes in that study. And then they were going to give once-a-week therapy in combination with lenacapavir orally. So 2 oral drugs that could be given once a week. And they were doing it with their version of a long-acting partner, which happened to be an NRTTI. And you can see substantial decreases in lymphocytes at 20 milligrams. And then all the way to the right is the studies of 0.75 milligrams q-day, showing again decrease in lymphocytes, and there was the same decrease in CD4, similar percent decrease in CD4. So it was all put on hold. And to their credit, the company's credit, they worked really hard at understanding this, and it was probably an apoptotic effect specifically in lymphocytes. It turns out lymphocytes are very sensitive to adenosine analogs, and this actually blocks adenosine deaminase, which is one of the things that gets rid of adenosine analogs. There are adenosine analogs that are treatments for B-cell lymphomas, so it's probably some specific effect on lymphocytes. So the once-monthly prevention program has been scrapped. It's no longer going forward. The long-acting implant for prevention, which people were really excited about, is being reassessed. And they have another molecule that they're interested in, which they've said publicly. But what is going forward is that once daily Islatravir doravirine, but notice the dose, 0.25, so 3-fold lower than the dose that caused the toxicity. And if you look at the bottom graph, this is CD4 change in a phase 2 study, and that top green line is actually Islatravir and doravirine given at with this Islatravir given at 0.25 milligrams. So you can see that CD4 increases were fine. In fact, slightly better, though not statistically better, than doravirine, 3TC, and TDF. And they've done very careful work suggesting that this dose of 0.25 is likely to be safe and not have an impact on lymphocytes. And that daily study is going forward, so a switch study going forward, a treatment-naive study with doravirine going forward, and a once-weekly in partnership with lenacapavir also going forward, but with a lower dose, not the 20 milligrams once a week. I think it's 2 milligrams once a week that's going forward. So they're going forward, but the once-monthly, and unfortunately the implant, the once-monthly is definitely gone, and the implant is being reassessed. So what about other small molecules? Usually I have like a whole long list. I don't have a whole long list. There is a 3rd generation INSTI being developed, and I put in, there's nothing published about it, but there is a link to the phase 1 clinical trial if you want to go there. There's a 2nd generation capsid inhibitor, same story, phase 1, meaning it's in humans, but not yet, there's nothing published. And then there's a series of maturation inhibitors, but all of them so far have failed. The most recent one failed because of resistance. Maturation inhibitors are tough, right? Because you're binding to a protein target, not an enzyme like integrase or protease or RT, and so resistance is really a risk. And I know there are some other companies that have integrase inhibitors and NRTTIs that are in development, but I couldn't find anything in the public domain that I could share with you, but you could look at these things if you're interested, and I think you get these slides. So here's the same slide that Paul showed, and so it's very helpful. Broadly neutralizing antibodies. So obviously we want broadly neutralizing antibodies potentially for prevention. We want to, be able for vaccines to elicit broadly neutralizing antibodies. And there's a lot of them, and they attach at different places all over the envelope. These are attaching against envelope. This is where they're going to work. You can really think about them in therapy as entry inhibitors. They're really entry inhibitors. That's what they are. They block entry. The problem with broadly neutralizing antibodies is what Paul went into in great detail, is they're broad, but they're not universally broad, right? Like I don't know, dolutegravir, bictegravir, they're super broad. They work on every integrase that exists except for the ones that are selected for rarely by resistance. Even our broadest antibodies may work great for subtype B, but not so great for subtype C, which is, most of Africa, or they might be better for subtype C. This PGDM1400, which is purple, that's a V1, V2, is actually better against subtype C, but not so good against subtype B. So they're broad, but they're not that broad. The one thing that is really convenient about them is you can manipulate them so they're very long-acting. Almost all of them can be manipulated. You change the Fc receptor. There are a couple different types of mutations you can do. That's what was done with a lot of the COVID antibodies, but they can be very long-acting, and I'll show you in a little bit. And there's even a group that's trying to develop antibodies that are tri-specific. So to get around the idea of, well, they're not that broad, or even though they're broad, is why don't we put 3 antibodies on one stick, right? It's one, the heavy chain stick, and then the binding sites. Put 3 on one, and that's tri-specific. And that is kind of stuttering its way forward, and we'll see what happens. So remember, they're broad, but they're not that broad. They can be manipulated to be very long-acting, and they target envelope. There are broadly neutralizing antibodies that go after cellular targets, but these are also entry inhibitors. Ibolizumab, some people here, you guys with the 500, I'm sure you've used ibolizumab. It's also an entry inhibitor. And then this, I think keep saying UB40, and Mike's gonna help me with UB40. I can't remember what UB, I think it's a group or a song or something, but it's UB421. That actually was in the New England Journal, but as far as I know, it's not gone anywhere. So here's an example. This is a CD4 binding antibody called N6. And this is just to show you that this was all done against subtype B viruses. So that's the type that's most prominent here in the US. And on the right graph is the susceptibility. And the farther you go to the right, the more resistant you are. And what you can see is there's a broad range against subtype V viruses in terms of susceptibility, like 1,000-fold difference between that red dot up on the upper left to that black dot or blue dot, whatever it is, way down on the right. And this is all subtype B, right? That for like integrase, that would be squished way down. And on the left side is actually a single dose. And not surprisingly, the more susceptible you are to the antibody, the longer it works. So that one person there was actually suppressed for 80 days with a single infusion. That's that darker line there. But some people were barely suppressed at all, that very light blue, Carolina blue line, that barely even got down to half a log. So even against the subtype, you see this broad variability. Okay, so what about long-acting therapy? What can we do for long-acting therapy? So we have Cabotegravir, right? Which is really great. It's integrase, so most people who are untreated, previously untreated, treatment naive, are gonna be susceptible. But what's the partner? Well, right now we have rilpivirine, which has some drawbacks, mainly NRTTI resistance. And then there's this convenience issue. You have to be shot in the backside. And so there was a presentation at CROI looking at thigh injections, which would be more convenient, maybe could be done outside of a medical situation, setting. And it certainly produced very good levels. But interestingly, the participants in the study who went from gluteal to thigh actually preferred gluteal because it was uncomfortable to get that much liquid into your thigh. So what about Cabotegravir, one of these broadly neutralizing antibodies? Well, the ACTG is doing a study you can see on clinicaltrials.gov with Cabotegravir every 4 weeks and this VRC07 523LS, which is similar to that N6 that I showed you. And that is ongoing. In fact, it's going to end, 48-week follow-up for 75 people is going to end soon, very soon, in the next month and a half. So we'll learn whether that works. So that's exciting. And then, of course, the company that makes Cab also is the one that owns this N6. So they're going to go forward with Cabotegravir plus N6. And they're actually looking at formulations of Cabotegravir that may have a longer half-life. So this is possible. It's possible. Well, what about lenacapavir? What kind of partners might lenacapavir need? And I'm going to show you two things. One is this phase 2 study. So this is a study done by the sponsor where they looked at lenacapavir plus 2 nukes. Lenacapavir plus FTC TAF, lenacapavir plus, or oral lenacapavir plus FTC TAF, or BF TAF. And you might say, oh, well, why are you doing this? You're giving a long-acting in pills. No one's going to do that for a sustained period of time. And you might wonder, I thought, what are they doing? And then at 28 weeks, when people got suppressed, they continued lenacapavir plus oral TAF, and they continued lenacapavir plus oral Cabotegravir. Now, why would they do that? Well, because that people are thinking about long-acting TAF preparations, right? There's been publications about long-acting TAF and TAF being in an implantable thing. And I know, even though it's not in the public domain, well, I don't know. I suspect that this company is actually thinking about long-acting integrase, and they want to show that 2-drug therapy works, right? That's what they're trying to show with this, at least in suppressed people, that 2-drug therapy works. And they showed that 2-drug therapy works. These people stayed suppressed for a long period on lenacapavir and then either oral TAF or oral Cabotegravir. And there were very, very few episodes of resistance emergence. Though in each arm, there was one person, except in arm 4, which was the BF TAF, there was a person who developed some lenacapavir resistance. But they're looking for partners. And you might ask, well, what about Cabotegravir as a partner? And I don't know. So this is the final thing I'm going to talk about. This is a study that I got to present at CROI, which went a different way for partners, right? 2 partners. So this is a menage a trois, maybe? I hadn't thought about that. It's lenacapavir with 2 antibodies, teropavimab, which is easy to say, and then zinlarivmab, which is a little harder to say. And they originally abbreviated this TAB and ZAB. And I said, I can't do that. I can't have TAB, ZAB, and a jab, because I'll turn into Dr. Seuss. Anyway, this was a study, randomized, blinded, of a long-acting regimen. Now, the important things here is people had to be suppressed. They actually had to be sensitive to both antibodies. And of the people screened, only about 45% could be demonstrated to be susceptible to both antibodies. They had to have a CD4 nadir above 350 and a CD4 entry above 500. And the randomization wasn't to placebo, because these are suppressed people. Everybody got treatment with lenacapavir and 2 antibodies, but we looked at 2 different doses of the ziralivimab antibody. And unfortunately, you might remember that lenacapavir's development was interrupted transiently because of a crystal formation and during the in the vials. That was a manufacturing issue that's been solved, obviously. But this was supposed to be a year-long study with 2 treatments, one at 0 and one at 26. It turned into a 26-week study with a year follow-up. So a single administration, no more pills, and what happened? Well, there were only 20 people, 10 in each arm, so not a lot of people, but 9 out of 10 people in both arms stayed suppressed for 26 weeks with taking no pills. One person decided they were uncomfortable and they went back on therapy. They didn't rebound, they just went back on oral therapy. They weren't withdrawn from the study, that's a mistake. They stayed on the study and stayed suppressed, but they were also taking oral therapy. And, one person did rebound. So one out of 20 people did rebound. Here's the rebounding person. We were very careful. Any rebound, immediately go back on oral therapy. So this person was 155 and then 534, and then they went back on oral therapy. As yet, we have not been able to sequence that higher viral load plasma sample. At baseline, of course, the person was susceptible to both antibodies, and we were able to look in the genetic material, the HIV DNA at baseline. There was no lenacapavir resistance. but additional studies are ongoing. The person had no impact on their CD4. And you might say, well, what about maybe they didn't have the right concentration? But the red line is that one person, and the shaded lines are the population PK for, now we got tab and zab, and lenacapavir, and you can see the PK was fine. So this is a possibility. There's a phase 2 study that is now being developed of these 3 agents, 2 antibodies and lenacapavir, every 6 months. And it's going to be not just one administration, it's going to be continuing 6 monthly administrations for people who are suppressed. Also, there's a pilot where we're looking at people that are susceptible to just one of the antibodies. That pilot is ongoing. 90% of people with subtype B are susceptible to one or the other antibody. You might say, oh, come on, who's really going to do this? And it's possible. Maybe no one is interested in doing this. On the other hand, some people might be interested in getting therapy once every 6 months, and potentially, if this works, maybe could reach some of the difficult-to-reach people. So here's my summary. The needs for new oral therapy are limited. I think less frequent dosing, maybe maybe weekly is possible. As far as I know, there's no real opportunity for monthly oral therapy, but the lenacapavir, islatravir study is now started and people are enrolling, so we'll see. Our current therapy is very high bar to replace them. And I think the other thing is the motivation for companies, right, to develop oral therapies might diminish because if you look at a very effective, well-tolerated oral therapy, fostemsavir, is really only being used for people who are failing and have high levels of drug resistance. And it's just not very commonly used, not because it's bad, but because those people are uncommon. I think long-acting therapy is a new frontier. Longer intervals, I think, are the first hurdle to overcome. We need to find partners to lenacapavir, and that's being worked on. I think it's going to be cumbersome to start, but there are a few people in the audience, I'm looking at one, who remembers probably setting alarm clocks for patients, or at least having colleagues that were setting alarm clocks for patients to take their AZT every 4 hours. Literally, we told them 6 times a day, every 4 hours, wake up in the middle of the night, take your AZT. So yeah, IV infusions are uncommon. It turns out in Johannesburg, you can go to an IV infusion bar. It's a bar. You can go, and if you want vitamin C, vitamin B, you can get saline if you're a little dehydrated. So who knows what could happen. I think BNAbs are promising, but there's a lot of questions about susceptibility, feasibility, cost, manufacture. And I think, to me, it's really small molecules is where we need to go. But in the interim, long-acting, broadly neutralizing antibodies might be a possibility for some people. Okay, so this is to make sure you were listening, okay? Which of the following human studies for HIV treatment and prevention are ongoing or starting now? Not before, but now, for the novel agent Islatravir. So go ahead and vote. The goal here is 100%. People are afraid to vote. We have to get better music. I can't waltz. I have no idea. Hopefully for your cases, Mike, we have an upgrade. All right, we can look any time. Daily oral and weekly oral, 39%. So 39% of you are awake. Long-acting implants are being investigated in animals, but any human studies are not being done. And then the monthly oral for prevention is out. And there are some studies that are actually ongoing right now. And the second question, which of the following statements is true? Which one is true about broadly neutralizing monoclonal antibodies? And you can see the choices there. I'm not going to read them. The keyword neutralizing. I'm hoping better than 39%. I know why you guys are asleep. It's the music. All right. Keep voting. You can do it. All right, there we go. We got above 50%. Excellent. They can be altered to support very infrequent dosing, but it's envelope that neutralizes, not gag or polymerase. Perfect. Okay. Questions, I guess. Don't be afraid to come up to the microphone.
Right. We already have a couple of questions, Joe.
Okay.
Let me just use this microphone.
Oh, yeah. I'll yeah, sorry.
So we do see patients who have rilpivirine resistance who would be good candidates for injectable treatment.
Yep.
So would that be somebody in whom lenacapavir might be something that would be possible?
Yeah, there's a lot of talk about that, and I think it's plausible and at least for suppressed people, likely to be successful. Based on the ACDG study and other studies where 2 drugs with Cabotegravir are likely to work. I don't know if it's feasible in terms of insurance. I also don't know, certainly Cabotegravir exists, right, as a prevention intervention. Whether you can prescribe Cabotegravir alone or whether you'd have to throw in the rilpivirine, even though you know it might not be contributing. But people are absolutely talking about this, and you very experienced people out there, there may be people where this is exactly appropriate. And I was just talking with Sandy about such a patient before. I don't, Monica Gandhi tells me she has a few patients on that combination in her cohort from UCSF, so I think it can be done. I don't know how hard it is to do it.
And related to Dr. Gandhi and her study at Retrovirus, so, we have patients who check every box on the social determinants of health questionnaire and have a lot of difficulty adhering or even in many cases beginning antiretroviral therapy. What additional data do we need to go with a direct-to-inject approach where you start people on long-acting injectables?
Yeah, I think that's an excellent question. So in the study from UCSF, I can't remember, I think there are like 130 people on the study, but 57, I think is the right number, 59 maybe, were actually viremic at the start. And so that's a pretty small number to really change. And it's important that these were people that these were people that were engaged with the clinic. Mm-hmm. They had to be clinic participants and have had visits in the clinic. I think we need a study, a larger study, that is replicated across sites, probably also in people who are at least engaged at some level before we start injecting people, when they leave Grady. I think we need more data from a broader group of people. That's what I think. But I think it's coming. We're working on it.
Okay. And do we have any other questions from the audience? I mean, I'll go ahead. Go ahead, Paul.
So just to follow up, I see a lot of patients like Dr. Lennox described. So they come to clinic, but they cannot take their medicine. And I would love to be able to give them an injection. So if I were to do that now, I don't think I could do it even if I wanted to because of insurance, right?
No, it turns out people are doing it. It depends a little bit on the insurance. At least in North Carolina, we've maybe done 4 or 5 people like that. I have 2 in my clinic. One was a methamphetamine addict who just said, I'm never going to take pills. I'll come to clinic every time, all the time, but I'm not going to take pills. He is suppressed. Another is a man who always said he was taking his medicine, but you call the pharmacy and they say, well, he refilled his medicine in June and then he refilled them again in December. And so he is also suppressed. But there's risk. But you can do it. You absolutely can do it. Now, whether people that have private insurance, you could do the same thing, I'm not sure. Who's done this? Who's given cabotegravir to a viremic person?
Fair number of people,
Yeah.
about half a dozen maybe.
Yeah, so people are doing it. I'm not encouraging it, believe me, I'm not. I would do this incredibly carefully, very selectively. They would be people that could come to clinic. It's 100% off-label, which if I didn't say that, I should have said it. But I think there is a subset of patients that might benefit.
Can I ask a totally different question? Can you comment about the safety of monoclonals versus molecular drugs that inhibit HIV?
Yeah, that's a really great question, and you know the answer to it. But the monoclonal antibodies that are directed at non-human targets, and which is all the COVID antibodies and all the HIV broadly neutralizing antibodies, have been very, 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 very safe. There are occasional infusion reactions, but they're actually pretty rare. And the other thing that's interesting about them is anti-drug antibodies are very uncommon, remarkably uncommon. Now, I don't know, when people start putting 3 heads on one antibody molecule, I don't know what will happen there, but they're very uncommon. So it's quite safe, and they're well tolerated. Again, it may be something people are willing to do.
Right, and I think it has the direct implication on the last study that you presented.
Sure.
Yeah, because if you could do twice yearly.
Yeah, no, I think it. I know that the VRC, the Vaccine Research Center, has 3 antibodies that they think are every 6 monthly that could be combined that attack 3 different targets on that really nice diagram that Paul showed us, and I reprised there. So it's possible, and I think having at least one small molecule, the lenacapavir, may have made the difference in that situation. And we'll see. Maybe that one thing about antibody susceptibility is it is predictive pretty well when people are viremic, which I showed you with that N6 one where it's not as clear that when you get a sequence out of HIV DNA, so an archive test, it's not as clear that susceptibility is as predictive. Mm-hmm. So that's why this pilot of single susceptibility, they're still getting both antibodies, but they're only susceptible to one plus lenacapavir. So we'll see what happens there.
So one question I had for you, which is an opinion, obviously. When we were routinely prophylaxing against MAC, patient satisfaction data and trials data indicated that a once weekly azithromycin was superior to the more frequent dosing. Mm-hmm. Do you think if we actually had a weekly therapy available for our patients that they would use it preferentially over daily therapy? I mean, what's your opinion?
Well, my opinion is that it'll be personalized, much like Paul said. I do think that there was a survey done at Duke, which I just hate to say that word, but Duke, and it's a 4-letter word, by the way, in case you didn't notice, and in South Carolina, and that was actually the highest preference for people living with HIV was once weekly oral. So I think, for certain people, that's probably just right. And people who have challenges of adherence, you could imagine, a weekly phone call or some weekly automated reminder that clinics could do. It's really hard to do it daily, but will people wholesale jump to that? I don't know. But I think there'll be a substantial proportion of the population. What do you think?
I agree. I mean, I think when I've talked to my individual patients about it, they would be more likely to take a weekly pill than a monthly self-injection. But that's, my small group.
No, that survey study said exactly that. Weekly pill versus every 6 months. I mean, if you have to come and get an infusion and you don't live in Johannesburg, that might be too much. But if there was a 6 monthly injection. The one thing I didn't mention about lenacapavir is even though it is only once every 6 months, it's 2 injections. I might not have mentioned that. And injection site reactions are quite common, and they can be sore, and not sore for 20 24 hours. They can be sore for multiple days or even
Yeah,
longer.
it sounded very similar to what we used to see with T20.
T20, right,
Yeah.
exactly. I mean, obviously you don't get injections twice a day. You don't have, 60 of them per month, but they are annoying, as it turns out.
All right, well,
Great.
that ends our question and answer period. Thank you, Dr. Eron.
Yes.
And we're, yeah.